Hello, everyone. We are live. So, Neil, we'll begin.
Yeah,
Thank you so
thank
much.
you, Shritika. Hello, everyone, and welcome to the webinar on antimicrobial awareness during the prescription writing. With that, MSCI is also like one of the large nationally, which was established back in October 2011. And it is also having nearly 20,000 plus members from across the states and the union territory of our country. We are also affiliated with IFMSA, which stands for the International Federation of the Medical Students Association, which was founded back in the 1951, which is also the oldest and the largest student-led organization, having nearly 1.3 million medical students as its part of its membership base. So with that, we'll have Hazik, who will be giving a brief introduction about the campaign and the AMR unit. Over to you, Hazik.
Okay, thank you, Neil. So basically, we all have gathered here to basically and celebrate, I should say, the World Antibiotic Awareness Week by different organizations, stakeholders who are part of this. We can say the burden of AMR. So the aim of this particular campaign is to increase the awareness and understanding of antimicrobial resistance amongst the medical students as well as the general population, and to encourage the best practices by different, you can say, stakeholders, and specifically medical students and the general masses in our own country setup, so that we can somehow reduce the emergence and the burden of AMR in future course of time, which is considered to be a silent pandemic. And for that, we have three distinguished guests and panelists who are here for this webinar. Moving on, I would like to introduce the AMR unit, which is established this year by MSCI India. So myself, Dr. Hazik, I'm the AMR unit coordinator, and we have very, you can say, ignited minds who are part of this AMR unit, who are working closely to, somehow encourage and somehow uh, reduce the burden of AMR, which is considered to be one of the major global threats. So this unit is working in collaboration with WHO India, and we tend to somehow in future course of time work on various issues of AMR, taking into consideration the various stakeholders as well, and thus propagating the important concepts and important issues regarding AMR, and thus reducing the burden of AMR. So with this I would like to hand over to Shrutika and Shikhar for further proceedings.
Thank you so much, sir. This webinar was created as part of the World Antimicrobial Awareness Week, as sir has already mentioned. So, AMR WHO unit alongside the Standing Committee on Medical Education, SCOMI, took forward this initiative to introduce the topic of antimicrobial awareness during prescription writing. And we hope that you would find this webinar as fruitful as we all had hoped. I would like to hand over to Jenil to introduce our expert panelists.
Good evening, everyone. I hope that this webinar is exciting and enriching for you. We have great sessions planned for you by some amazing faculties. So I'd like to introduce our panelists for this webinar, starting with Dr. Bhavesh Divani. He's MD Dermatology and MBBS from MP Shah Medical College and LLB from Saurashtra University. He has over 30 He has over 30 years of experience of clinical dermatology and has served as the past president of the Indian Association of Dermatologists, Venerologists, and Leprologists, Gujarat State Branch. He is a pioneer of cosmetology and laser technology in Saurashtra and has been the co-author on the Book of Pigmentary Disorders at class of IDBL. He is also an international and national faculty and has presented papers and lectures in conferences like the WCD in Vancouver. Next, I'd like to introduce Dr. Mahesh Gupta, who is MD DM and Director of Academics and Professor and Head of Pharmacology at the World College of Medical Sciences and Research, Jharkhand, India. He has formerly been the director and dean of other colleges as well, and has a professional experience of over 39 years. He has been awarded fellowship of the International Medical Science Academy as well as the Bharat Jyoti Award. And finally, I'd like to introduce Dr. Manisha Devani, who is MS Ophthalmology and MBBS, also from Ambisham Medical College, and has 25 plus years of experience as an ophthalmic surgeon with a keen interest in phaco and LASIK surgery. She has served as a national faculty at several ophthalmic conferences, including Delhi Ophthalmic Society, and has been the recipient of the IMA Best Lady Doctor in Gujarat Award in 2013 and more. I'm so glad to have all of you with us on this important webinar, as AMR is an important issue that we're currently facing, and it requires systemic efforts from all of, especially from future healthcare professionals at MSI. So I'd like to start off with a discussion, and we'd start off with some clinical case vignettes where we will identify what kind of issues there are and how we can better approach these cases and try to reduce AMR and try to connect better with patients. So I'd like to start off with the first case. Okay, so in the first case, a 14-year-old female patient approaches the ENT OPD. The doctor is busy and has a lot of patients on the register, and the patient with complaints of ear pain is diagnosed with acute otitis media. So the doctor prescribes her amoxicillin 500 milligram for 10 days, twice a day. But since he is busy, he does not explain this to the patient properly. The patient in turn stops taking the antibiotic once the pain suppresses, and later on she develops recurrent otitis media. So I'd like to ask one of our panelists, Dr. Manisha ma'am, what kind of risks can come up with such a discontinuation, and why is treatment duration so important to explain to the patient, and why should all prescriptions also mention the duration properly and in a proper format?
So, very good question, Jainil. First of all, good evening to all young doctors of MSCI, and especially good evening to Dr. Mahesh Gupta and Dr. Bhavesh Devani too. So this is a very good initiative, and your question is about patient has stopped antibiotic in between. Especially, I would like to tell all the young doctors that whatever is the number of patients waiting behind, you have to give important time to explain the patient even after diagnosing the patient that how to take the medicines. Because if the patient stops the medicine in between, there is a risk of antimicrobial resistance that we know, but the patient doesn't know. So we have to explain the patient that even if you don't have a symptoms after 3 to 4 days of taking medicine, especially antibiotic, even though you have to complete the course, so there is no risk of recurrence or recurrence otitis media. So that we have to explain the patient, and to give some important quality time to explain about the risk of stopping medicine in between to the patient is very important to prevent antimicrobial resistance in community as a large. Especially, I always like to explain the patient in their own language. Especially when we write a prescription and even explain everything in written, it is very important to explain verbally in the language of patient that you should continue this medicine, especially for the given prescribed time. And even if he is having some complaint in between because of medicine, he has to contact his physician before stopping the medicine. Anything else you would like to know?
No, thank you so much, ma'am. That was a really well put explanation. We'll move on to the second case now. Okay, so in the second case, this is a very typical case that is seen a lot in the OPDs. A young patient, 12-year-old female, approaches the general physician with a common cold, with typical symptoms of sneezing and nasal congestion. She gets prescribed anti-congestion drugs, as well as a 3-day course of azithromycin 500 milligram BD. Is the antibiotic indicated in this case? I'd like to again direct this question to Dr. Manisha ma'am.
It is really a very good question, and all young doctors should know that only having sneezing and nasal congestion is not the identification that patient is having infection also, along with bacterial infection also, along with this simple rhinitis. So always ask the history first. And if there is only sneezing, nasal congestion or rhinorrhea, then better to start with some symptomatic treatment. And we have to start antibiotic only if there is a total count or WBC, total count is more, or if patient is having some indication like fever and something that indicate that there is a bacterial infection also. Never start directly the antibiotic along with the simple anti-symptomatic treatment. Here I would also like to convey that there is so many allopathy allopathic medicine and antibiotics prescribed by the doctors of other pathies also, which don't know what is the risk of antimicrobial resistance. And because of that also, we are getting so much of problems nowadays. So we have to educate patient also that always take medicine with the prescribed prescription and with the advice of doctors also. Thank you.
Thank you so much,
Thank
ma'am.
you so much,
We'll also
ma'am.
I think
request Dr.
I
Bhavesh to share his views.
yes, yeah, I need to say something on this. See, we always talk of the fact that AMR is basically because of the unnecessary use of antimicrobials. That is one of the major contributors. And common cold is one such situation where invariably the clinician end up prescribing antimicrobials when they are not needed. In fact, it is generally said that even other treatment also you need to look at them critically. I would say a famous saying here: if you want to treat common cold with drugs, it takes 7 days. If you don't give anything,
It's
it
really
takes a week. It takes 1 week. So that is a very large truth. So I think this is one example where there is unnecessary use of antimicrobials, which has really done the damage. So I think we need to be very careful in such patients.
Yeah, yes. Yes, antimicrobial resistance is a very common, and as per the WHO, is the top 10 health problem, and we are facing them in and day out. The main thing, don't directly jump over to the antibiotic starting. Many times some viral infections, these are the self-limiting. Our body's own immunity will direct to the patient healing within the 7 days, as sir has already told. So whenever necessary, always and always counsel the patients properly. Yes, it will take some time. Many times we are not knowing, it will may take 3 to 4 days to resolve the complaint. But always in the viral infection, it requires some time to get the patient symptomatic free. So it doesn't mean that we have started the antibiotics. So we have to take care while prescribing and any antibiotic in the such type of the common cold, and maybe some allergic rhinitis is also there. Simple giving the antihistaminic like levocetirizine or the neurobilastine, then it may solve the problems of the patients. No need to give the antibiotics.
Thank you so much to everyone for your really valuable inputs on this. Okay, moving on to the third case. This is a really interesting one. A 33-year-old female is diagnosed with fungal UTI caused by Candida species. So it is known that it's being caused by Candida species. She is also a chronic diabetic with uncontrolled sugar. The doctor prescribes an antifungal treatment as required. The patient, after 9 days, develops a secondary bacterial infection. So in this case, I would like to ask you, why is it important to alter prescriptions based on the history of the patient? Should this patient have been preemptively given antibiotics? And how important is it to mention advice in the prescription, such as maintenance of hygiene as well? I'd like to start with Dr. Manisha Devani and then Dr. Mahesh sir, please.
Yes, Jainil, this is really a very important thing you have mentioned here. That is, we have to ask the history of the patient. And in this history, there is a uncontrolled sugar, means a chronic diabetic patient along with Candida species urinary tract infection, right? So in this case, there are chances of development of the secondary infection as the patient is having a low immunity level because of diabetes. So in such type of cases, it is better to give a course of antibiotic along with antifungal treatment. And it is very important to maintain the hygiene, and we have to advise the patient to improve his hygiene if it is not good. So it is not only that we diagnosed it as a fungal infection and we give antifungal and the cause is solved. We have to think multifactorial way. So in this case, I would like to say that along with me, there is a dermatologist also here. So you can take opinion of both these doctors, Dr. Mahesh and Dr. Bhavesh also.
Yes, Dr. Marshall.
Hello. Yeah, but my take on this particular case would be that I think the more important factor here to first realize is that, which has already been said about, that patient is an uncontrolled diabetic, which is a risk factor, for such kind of patients. And add to that, if there is a poor hygiene, then chances of contracting a fungal infection would be very, very high. But when there is a fungal UTI where we are finding out candida, this definitely would need treatment. As regarding the question of that, should we give preemptively, give the antibiotics? Well, there lies the catch. I mean, this may be catch 22 situation, I would say, that if we have the other factors in mind, it may not be a very bright idea to start with the drugs preemptively. But if we have the features which are indicating clearly that there is a secondary bacterial infection, then maybe we'll have to give empirical antimicrobials. But I think we might have to modify the treatment based upon the culture sensitivity report. So I think in such kind of patients, it's always very, very important that before we start with any antifungal or antimicrobial drug, that is antibacterial drug, we must collect the relevant biological specimen. That is urine here. We need to go for culture sensitivity, find out which organism which we grow, and then accordingly, as per the sensitivity pattern, we need to convert the empirical treatment into definitive therapy. So that would be the right choice here.
Yes, fully agree with sir.
Dr. Bhaveshwar, on this note, I'd also like to ask you, what is the importance of empirical treatment, and how can we make sure that we are prescribing an empirical antibiotic treatment and not going into, unjustified or like just using antibiotics carelessly? So, what is how do doctors find the difference between them on a case-by-case basis?
See, many times we are have to, before we order the culture sensitivity reports. Many times it will take it will 72 hours to develop the colony and what are the sensitivity tests. Meanwhile, we have to choose the broad spectrum antibiotic according to the patient's clinical condition or associated comorbidities. Because patient's comorbidity we have to address first. Then and then only we can get the results. So this is in your cases, this is the case of the uncontrolled diabetes. It is a comorbid condition. So we have to treat the diabetes meticulously, and starting of some empirical antibiotic like broad spectrum antibiotic. If we are suspecting the gram positive, coverage the gram negative, so amoxicillin, clavulanic acid. But yes, again, it should be given in the full dosage as per the kilogram of the body weight. The empirical treatment is not like that we give in the pediatric dosage or the subtherapeutic dosage. That is very important. First thing to be kept in the mind. Second thing, as already told, it is a comorbid condition to be treated simultaneously and judiciously use the antibiotic. And if needed, in your cases, antifungal and antibiotic, because the patient is a case of the diabetes, the chances of the secondary bacterial infection is big. So empirical antibiotic must be the broad spectrum antibiotic. That is the my take-up message.
Thank you so much, sir. Dr. Manisha, ma'am, would you like to comment on anything that similar to this, which is seen specifically in the ophthalmology OPD, since that is your area of specialty?
Yes, in our branch, if you see in ophthalmology, there is always a charitable trust and charitable camps are held everywhere. And in that camps, patients are coming especially for getting drops and just to come and ask to us that give us some drops and we will put and our eye will be clear. In that case, in so many camps, people are taking antibiotic drops. Like previously it was ciprofloxacillin, now they are giving moxifloxacillin even. So in so many patients are putting these drops regularly for a longer time, and they develop resistance. Even keratitis medicamentos are too. So especially for ophthalmology, there are so many young doctors listening this, that whenever you come across such patient in your at MBBS level, and if they are asking for drops, we even if we want to prescribe, we have to give only tear substitutes. Never prescribe any antibiotic drops unless and until it is required and there is a proved infection in eye. That is very important message from my side, and it is happening day in and day out. Everyone, all general practitioners and every camps, we are seeing these things.
Well, I need to say something regarding empirical treatment. Generally, empirical treatment should not be treated that you need to throw arrows in the dark and then hoping to God that some of the arrows, they go and, at the right spot. So empirical treatment also needs to be scientific. It has to be very scientific guess. Now here in this particular case, like what I would like to know is, there is a chances that it may be a recurrent infection. So patient will be having the old records also. He will have the last culture sensitivity report also, all right? And then you can take a urine specimen, study it from microbiological point of view. You can go for gram staining. You can go for ELISA readers. You know, there are certain tests which are known as rapid molecular tests. So waiting for the culture sensitivity report, because it will take 24 to 48 hours, we need to give something, but that something should not be just a wild guess. It needs to be a logical, scientific guess. That is what empirical treatment is all about. And here we must consider the other factors from history, and then we can do some rapid tests, which will give us a fairly good idea regarding the organism. And we still can have a very reasonably scientific, good logical choice as far as the antimicrobial is concerned. So that's my take on this.
Thank you so much. Those are really valuable inputs. Okay, moving on to the next case. A 45-year-old male develops Staphylococcus cellulitis, but on culture the organism is MRSA. Hence, he is prescribed vancomycin. The doctor again does not counsel the patient about possible side effects. A few days later, the patient shows up with typical signs of gastric upset and diarrhea. The patient quits the treatment and the organism becomes more virulent. What could have been handled better, and why is it important to counsel the patient about side effects beforehand, especially when prescribing drugs such as antibiotics or antimicrobials, which should not be discontinued? So I'd like to direct this question to Dr. Bhavesh Devani and then Dr. Mahesh sir.
Yes, Jenny, it is very important to counsel about this many side effects. Sometimes what happens if we prescribe such type of the antibiotics, there is a disturbance of the gut flora is also there. So the chances of the diarrhea, gastric upset is a very common in such type of patients. So it doesn't mean the patient can stop the treatment. We have to counsel the patients, and simultaneously, if there is a patient use any history of any gastritis or gastric upset or anything because of the drug induced, simultaneously we can use the PPI like the pantoprazole or the rabeprazole. So this is the main thing we have to counsel the patient. That is very important.
Thank you, sir. Dr. Mahesh sir, your inputs.
That when we are dealing with an organism which is a MRSA, this is a danger signal, I would say. There are certain organisms which are difficult to manage and they have high pathogenicity. This is one such example. If I am dealing MRSA as a doctor, and when I give a drug like vancomycin, it is absolutely essential that first you explain to the patient what patient has. You need to explain to the patient that this is the kind of treatment I am giving to you. I need to counsel the patient the importance of adhering and complying with the instructions being given. And then, of course, sometimes since we are already expecting some ADRs, we need to prepare the patient mentally that some problems can happen of this kind, but this should not lead on to discontinuation of the treatment. They can be settled, or if at all this is troubling you, you can come back to me and we'll do something about it. Because leaving MRSA untreated after a day or two of antimicrobial treatment, this can have very serious consequences. So I think it's absolutely essential in such cases that we need to counsel the patient and tell the patient regarding the importance of compliance of the treatment. Thank you.
Thank you. Thank you so much, sir. So I think this is showing us students that no doubt AMR is a very huge problem that we need to spread awareness about to try to tackle the bigger aspects of it. But on a day-to-day basis, when we deal with AMR, there are small things that we need to keep in mind that, would help us mitigate it in whatever small way possible. Okay. So that brings us to the end of all the clinical cases. And before we move on to some more interesting topics and the prescription writing, I'd like Haziq sir to summarize all the cases that have been covered.
Okay, thank you. Thank you, Janil. So first of all, I would like to, appreciate to all the keynote speakers who are present here to throw light on these particular cases, which we basically experience in our, in our day-to-day practice. And to have their expertise and their point of view and their, important pointers, which we as aspiring medical students and future clinicians should take into consideration is something which is very essential for us to understand at this point of time. So there are a couple of, takeaways from this particular case discussion which we have. Like, for example, as Dr. Mahesh, Dr. Bhavesh, and Dr. They have highlighted the very important issue of that we just don't have to get into antibiotics at first contact with the patient. We need to first take into consideration the history as well. We need to take into consideration the associated comorbidities which are present. We need to take into consideration the culture and sensitivity of that of the biological specimen, as Dr. Mahesh mentioned in one of the cases, that it is essential that whenever we start empirical antibiotics, we need to tailor it down. And then we need to understand that there is a difference between empirical antibiotic and definitive therapy. Also, since Dr. Mahesh having a very larger expertise on pharmacology, he also very rightly mentioned about we need to understand the pharmacodynamics and the pharmacokinetics of every drug in relation to the host factors as well. And Dr. Bhavesh and Dr. Manisha ma'am, they very rightly mentioned from their own years of experience in ophthalmology and dermatology, you can say their practice, that we need to understand that the antimicrobials, they are not only something which can be given as a pill, because then that adds to the burden of different resistance microorganisms getting mutated, and further, we have shortage of antimicrobials, and this adds to the burden of antimicrobial resistance. So they very rightly mentioned, which I would like to summarize, that there are difference. We need to identify the opportunities, and we need to switch down to definitive therapy after we have started the empirical therapy, taking into consideration the culture and sensitivity results. We need to understand that there are certain symptoms which may mimic bacterial infection, but they are not bacterial infection. And this is the case which is rampant in our scenario, that for viral infections and for normal common cold and flu like experiences, we are taking antibiotics, and which is something which we as medical students, aspiring medical students, and the audience which are present here, which they need to realize that this is somehow we need to realize and we need to curb it down. Furthermore, I would like to highlight the importance of you can say the primordial and the primary prevention that is very essential. So in most of the cases in COVID-19 also, we have essentially seen that hand hygiene has become a very important part. And so these are the factors, because at the end of the day, it's the agent, the host, and the environment, the epidemiological triad which we basically study, that plays a very vital role in terms of having a particular pathogenesis of a particular organism. So it's not only the host factors, but the agent and the environmental factors which we also have to take into consideration. And as Dr. Manisha ma'am rightly mentioned, that hand hygiene is something which is coming into forefront right after COVID-19. So these are the you can say primary prevention modalities also which we need to practice, just rather than just depending on antimicrobial measures. So at the end, these are the basic pointers which we have gathered from this particular discussion. I would like to thank all the keynote speakers. And if they want to add anything which somehow can be a take-home message for the audience, they are feel free to add. Dr. Bhavesh, Dr. Manisha ma'am, and Dr. Mahesh sir.
One thing I would like to over here, the main part of the things that in the dermatology, in the day out and day in, we are facing some problem with the superficial fungal infection. That is the Tinea cruris and Tinea corporis. That is a dermatophytosis. So nowadays we are seeing the more and more cases of the recalcitrant dermatophytosis. So what is the recalcitrant dermatophytosis? Recalcitrant dermatophytosis means when we are giving the standard dosage of any antifungal, the patient is not responding. So now why patient is not responding? We are having done too much trial of this. The main and one of the most important cause for this is that patient is using the topical corticosteroid self-medications. They go directly to the medical stores or any general practitioner, those who are having a misdiagnosis, or sometimes there is a local application, they contain the potent corticosteroids. This potent corticosteroid is a clobetasol propionate. Once we are, patient is applying, there is in the short time, there is inflammation is reduced, pruritus is reduced, patient feels better for the 1 or 2 days, and again, the fungi that is goes inside, and chances of the routine itraconazole resistance, fluconazole resistance, terbinafine resistance is too many. There is a MIC of the terbinafine. There is a clinical trial already been established, and it has been published in the peer-reviewed journal that the chances of the terbinafine resistance is nowadays more. Fluconazole resistance, even in the candidal species, there is a fluconazole resistance is there. We are using sometimes the voriconazole. So these types of the higher antifungal we have to use. So what my take-home message is that initially what we are giving the same fluconazole, patient is cured the superficial fungal infection. But nowadays we have to give the itraconazole continuously for at least for 4 to 6 weeks. That is the 45 days, and it is the optimal dosage. We may higher the dosage of the itraconazole like 5 milligram per kg. So if we increase the dose of the itraconazole, chances of the hepatotoxicity and the drugs adverse effects and the economical burden to the patient will be more. So these are the things to be kept in the mind. Never use the topical corticosteroid in the dermatophytosis. My take-home message is that, and always counsel the patients to use the antifungal drugs with the proper time and duration, and associated with this comorbidities like the atopic dermatitis, diabetes, and tight cloths, and everything is be able to eliminate the spores also of the antifungals by the washing the clothes with the boiled water. These are the things we have to counsel first. And adherent to the antifungal regime is must. So we may face, because see, since last many years, we have not found any new antifungal in the market. It requires lots of the research going on. Sorry, maybe agree. Say in the corona era, there is a mucormycosis is there, and we are using the amphotericin B and posaconazole and everything antifungal. But we should not use such type of voriconazole and posaconazole in the superficial fungal infections. That should be reserved only for the deep fungal infection or mucormycosis like this. So always and always give the full course, and the counseling is must to treat the fungal infection.
Thank you, sir. Thank you, sir, for sharing your very valuable clinical expertise and your experience. And this is something which we have commonly seen. So few important pointers: that counseling of the patients, taking history from the patients in a proper detailed manner, thus establishing a good communication with the patient, then having a good follow-up with the patient, taking into consideration the broader picture of that particular, pathogenesis of that particular infection. And again, as you mentioned, that people come with topical corticosteroids and then they have that resistant infections, the recalcitrant dermatophytosis, which is very commonly seen in OPDs and in this particular, hospital setup. So these are the valid points which somehow we as medical students can imbibe when we enter into the clinical practice, and somehow we can, reduce the burden of this AMR resistance pool. Now I would like Dr. Mahesh sir to give some inputs.
My one take-home message: never prescribe the topical steroid in superficial dermatophytosis.
Thank you, sir.
Okay, so dear friends, since all of you are young students and tomorrow's prescribers, and we have been doing lots of mistakes, and we are giving you a bad scenario as a legacy, I would say, because we have not done our job well. So you don't have to repeat the mistake, and you need to do it right. And doing the right, I think we have all understood the importance of when actually rational use of antimicrobial is absolutely a must. And for this, I'm going to tell you something very, very important. I want you to learn it cerebrally. That means we need to use our brains as to what I'm going to say. And then we have to practice it spinally. I hope you understand the meaning of what I'm saying. Spinally means it should be happening as a reflex to you. The moment you suspect an infection and you want to give an antibiotic, a spinal reflex should start, which should answer certain questions. And these are 10 questions which you need to ask always. And I always teach my students that these 10 questions are like 10 commandments of Bible, all right, which need to be absolutely followed, understood. And I'm going to give you all these questions in brief. Question number 1, we need to decide whether an antimicrobial is indicated or it is not indicated. For acute life-threatening infections, yes. For acute infections with a lot of morbidity and some chances of mortality, we need to use them. Some local infections like empyema, pneumonia, etc., we need to give them. But think of diarrheas, generally not needed. Viral fevers, not needed. Common cold, not needed. Fine. So similarly, you will find many other situations where you don't have to give. So establish thing number 1. Question is it indicated? Give it some thought. Second question, always take the relevant biological specimen before starting the antimicrobial. This I have already emphasized. Question number 3, for starting the empirical treatment, you need to make a best guess of the organism. And it is, I'm talking before culture and sensitivity. By the history of contact, patient has come from Africa, history of travel, history of some kind of epidemic coming from the endemic area, the previous culture sensitivity report, history of keeping a pet. Your profession even can tell you sometimes of infection. For example, a fisherman, he may be having some features, and by the profession only you can diagnose that patient may be suffering from Lyme's disease. All right. So all these things, they become important in identifying a rough guess about the organism. Number 4, once you have guessed the organism, you have to start with the best drug. And you said it already, that what is important is PD-PK basis. PD basis means specificity, selectivity, all right, and post-antibiotic effect, etc. When we talk of the kinetics, the most important thing is the drug entering into the area where it should enter? Let me give an example here. Meningitis is a life-threatening condition. The report from microbiology tells that antibiotic X is highly active for meningeal organism, all right? And I start treating the patient and my patient dies in spite of the treatment. You know what has gone wrong? Drug doesn't cross the blood-brain barrier. So if I do not know that my drug crosses the blood-brain barrier, why am I wasting it on meningitis? So such kind of problems, they can be very serious. So that was question number 4, the best drug out of all the options available to you. Number 5, consider if an antimicrobial combination is needed. We try to use combinations left and right without any scientific kind of attitude. That is the wrong one. There are only very limited indications for using the antimicrobial combinations. Like patient has a polymicrobial infection, patient has a life-threatening infection. We want synergism. We want to delay the resistance like in tuberculosis, fine. We want to treat an immune compromised person. We want to treat a hospital-acquired infection. So there is a limited list of the indications for which we must use combination, but not combinations in routine all the time. All right. Question number 6, give it by the appropriate route of administration. Fine. Very serious infections, you always start with IV, but ultimately you need to go for switch therapy, shifting on to the oral administration, depending upon how patient has responded clinically, how the blood counts are responding, is the GI function normal or not normal. This is the criteria for starting from IV to oral treatment. Fine. The next is using the best optimal dose. That is number 7. Number 8 is deciding, does your treatment need a modification? Here the modification means going from empirical to definitive therapy. Fine. And then lastly, deciding on the duration of treatment is very, very important. All right. The general rule of thumb, like we discussed a case where the prematurely antibiotics were closed. If the doctor would have suggested to the patient that after there is a clinical cure, you need to add at least 2 more days, that is how you decide. But then all infections, they have different kind of durations. And for this, there is something, question number 10, test for cure. Test for cure means cure is clinical cure, microbiological cure, pathological cure, serological cure, hematological cure, radiological cure. So depending upon whichever is relevant to a particular case, you should test for cure, only then stop the antimicrobial drugs. So if these 10 questions, by and by, when you start practicing, in the beginning, it might take you 5 minutes to go through these questions. In 6 months, you will come and reduce the duration to 2 minutes. And when you have a 3-4 years experience of clinical practice, it will happen in 10 seconds. All right. So you don't have to remember my lecture. This is something which need to stick forever here. And that is why I said that after a year or 2 of practice, it should happen to you spinally, not cerebrally. Fine. So please remember these 10 questions. If you follow this question, you will never be wrong in your antimicrobial usage. Fine. Thank you.
Thank you, sir, for your, very 10 golden points of how we can practice in future course of time and reinforcing us with these important pointers, which in a very systematic manner. Now we'll just take a quick remark from Dr. Manisha ma'am, a take-home message for the audience, and then we'll move on to the second half of our webinar.
Yes, already Dr. Mahesh and Dr. Bhayas covered so many things. On behalf of one more thing is, it is not only our duty to prescribe the medicine and give it to patient. Counsel the patient. It is also very important, as much as that is important to diagnose the disease, to prescribe the medicine, and to give the medicine to the patient. But counseling of the patient is as much as important as you diagnosing the disease. Just counsel the patient properly. That's the only thing I want to tell now.
Thank you, ma'am. Thanks a lot, ma'am. Over to Shrutika, Shikhar, and Janil.
Thank you so much to all three panelists for their extremely valuable inputs on all of these things. Now we'd like Dr. Mahesh, first of all, I'd like to thank Dr. Bhavesh Devani and Dr. Manisha Devani for giving on the really valuable time and coming on such short notice and giving such a good clinical experience, clinical side of things. And of course, I'd like to thank Dr. Mahesh, sir. Your 10 points are extremely valuable, and I'm sure that all the audience and us as future doctors will keep them in mind and try to implement them to the best of our abilities throughout our practice. Sir, now I'd like you to take us through the basic format of prescription writing and how, what are the things that we need to keep in mind while writing prescriptions from an antimicrobial resistance point of view. Yeah, so that would be a really good, second part of this webinar that would tie all of the learnings together and give us a point of view on the prescription writing practices as well. Please, sir.
I think, Neil, would you upload the presentation which I have sent to you?
Yes, sir.
So I'll do it in two parts. One, I'll go through the presentation and give you the basics regarding prescription writing. And then in a minute or two, I'll be discussing about the medication errors also, that how the things they go wrong. Okay, fine. So please let us have the presentation. Once you share it, then I'll start with it.
So just give us a second. We are sharing this.
Yeah, take your time.
So by the time we are having the screen sharing, we have some questions in the chat. So maybe we can focus on that by the time.
Meanwhile, I would like
Yes,
to
sir.
add one more thing.
Sure,
Mr.
sir.
Neil, I would like to. The one thing we are using the Dapsone in the leprosy. Yes, sir, is knowing that is introduced in the 19 and 15 the leprosy. Nowadays, we are seeing the more and more persistent case of the leprosy. So every medical doctor should want to know to treat the leprosy. Dapsone resistance is there. Then in the 1960 or 1970, there is an MDT has been introduced by the WHO to counteract this problem of the anti-leprotic resistance is there. So MBT is a multi-drug therapy has been introduced in the 1982. They have added the rifampicin and then clobazamine. So what I want to convey here that the drug resistance, antimicrobial resistance, many are not, it is drug related only, but many times there is a genomic development of there is a new genes development of the DNA pattern of the, some antimicrobial that also leads to the resistance. So we have to keep this things also in the mind. The newer drugs like rifampicin, minocycline, rifapentine, ofloxacin that we are using in the leprosy also. And the extended period, initially we are giving for the 6 months or 12 months. Nowadays we have to may increase up to the 18 months. So there is a very important as far as the leprosy is also concerned about the antimicrobial resistance there.
Thank you so much, sir. We would request Mahesh sir to please continue with the presentation.
So
Is the presentation visible?
Slide mode, please. Can we?
Yes, sir. Is it visible?
Yes, Shrutika, but can you switch on to full screen mode for each slide? The screen is visible.
I think you can try resharing the presentation. Meanwhile, Shika, you can take the question.
Is it visible
Yeah, now it's visible.
All right. So can we go on to the next one?
Yes, sir.
Next slide, please. All right. I think this is the first I would like to share with you. Sir William Osler said it. The desire to take medicines is one feature which distinguishes man from other creatures. The doctor's visit is not thought to be complete without a prescription. I mean, even you can think about it, that you want to go to a doctor. At the outset, right at the reception, you pay 500 rupees consultation fee. And the minimum thing which you expect from the doctor is that he gives you a paper. On that paper, you will write your particulars, some diagnosis, some treatment, some tests, etc. So prescription is something which is a must. If he doesn't give you a prescription, you would like to have the refund of your money. All right. So that is how important the prescription is. And now I'll have some transparencies which are in lighter mode. So you feel good, but you get the message as well. The next one. And right in the beginning, I'd like to say some challenges which become a kind of making your prescribing very difficult. The pharma industry. Pharma industry is something which is absolutely commercial. They only are interested in this thing, prescribe my drug. Every medical rep who will come to you will always tell you, sir, my drug is the best. So you prescribe my drug. Now government has its own restraints. They will always tell you spend less. Okay. Insurance bodies, they also don't want to pay large amount of money. So they will also say spend less. And then NGOs and bulletins, they would pressurize you to do the right thing, that is prescribe appropriately. So we need to work in front, keeping in front these challenges. Next one. And see, this is one of the challenges. Patient. Can you see here what is happening? Right now, I take a blue pill, a purple pill, an orange pill, a white pill, and a yellow pill. I need you to prescribe a green pill to complete my color collection. So this is the kind of pressures sometimes you need to face where patients, they demand treatment from you. Next one. So here again, there is a problem. The patient is saying, I take so many medicines because my doctor prescribes them, and doctor is being defensive. I prescribe so many medicines because my patients expect them, right? And many of the young doctors, they believe that larger the prescription, more beautiful it sounds. But let me tell you today, the best prescriptions should be the smallest ones. And there is a famous saying I'll share with you here. A bad doctor treats one disease by using 20 medicines, and a good one treats 20 diseases with one medicine. So please remember this message. The shorter and smaller prescription is always more emphatic and more beautiful. Next one, please. Now see this patient. The patient can be very, very complaining. I have been taking this medication for 50 years and I'm going to sue the doctor. The side effects made me wrinkled, fat and bald. Fine. And he has been taking the medicine for the last 50 years. And he started it when he was 30 years old. So now the patient is 80 years and he is ready to sue you for the wrinkles and the loss of hairs. Next one. And look at this one. These days, everyone is internet savvy. In fact, most of the patients, they explore the internet first. They learn so many things, and sometimes maybe they are more knowledgeable than the prescriber. And look at this one. The person is saying, we know the medicine, just prescribe the disease. All right. So this can be another challenge. Next one, please. All right. So coming to the prescription part now. Prescription writing is an art. Please believe me on this. It's a skill and an art. And art is something which you need to acquire. You need to acquire with the knowledge background and then practice it slowly, steadily, read all the guidelines, and that is what will make it a skillful job. So once you write a prescription, what do you need to take into consideration? You need to take that into consideration that you use appropriate drugs. You need the appropriate doses. You need to rule out if there is any contraindications. You need to find out any drug interactions. And let me give an important information. As a pharmacologist, I'm sharing it with you. As and when you prescribe more than 4 drugs, a drug interaction has already happened. If you are prescribing more than 4 drugs, it is absolutely essential that you will have some kind of drug interaction. It may not be clinically important, all right, but it will happen. And then you need to consider the side effects of the drug. And if everything is good, then cost is also a factor, right? So these are the things you need to consider. Next one. So you need to have the background knowledge. What does it mean? Prescribing is a significant component of job for a doctor, specifically the young, newly qualified Indian medical graduate. It's a complex chain of competencies which needs a combination of knowledge as well as skill. And it's a challenging task for which they need to prepare themselves for this. All right. So, why the problem? Why it is a challenge? More medicines with complex pharmacology are being made available or they are being banned. Patient populations become older and they become more vulnerable to the problems. Chances of litigation may be there. There is a greater need for considering cost effectiveness. And then these days it is imperative that we use the medicines as generic medicines. So these are few of the things which we need to learn. Next one, please. So steps of good prescribing. The following steps are essential before a prescription is made. To have clarity about the reasons for prescribing, you must take patient's medication history, which we usually do not do. We have to find out history of any allergy, history of any past problems with the drugs. That will help you in making the right choice. We need to consider other host factors which may have alterations of benefits and harms, because our main aim is that benefit has to be absolutely much more than the harm which we can cause. So we need to work on what is known as principle of non-maleficence, primum non nocere. First, do no harm. That is very, very important. That is the basic thing which was said by Hippocrates, the oath of which you always take after completing your MBBS, that primum non nocere, first do no harm. To consider patient's financial status and expectations, and to know about the efficacy, safety, and cost effectiveness of your medicine which you intend to use. Next one, please. The more things you need to know is national guidelines on use of drugs. You must have a copy of National List of Essential Medicines. As of now, we are still using 2016 version, but I understand the 2022 version has already been made available. I really don't have the idea whether it is already notified or not, but I think we are going to have a new essential list of medicines for our country right this year, 22. All right. So we must be using most of the medicines from the NLEM. We should be clear about the legality of the prescriptions. We must monitor the outcome, whether it is beneficial or adverse, because we have to take care of both of these things. We have to communicate to the patients properly. This is what we are already talking again and again. And we have to tell the patient regarding the importance of the medication adherence. And of course, we need to work within the limitations of one's knowledge, skills, and experience. And here I need to share something which is very important. They have conducted a survey that how many medicines one can remember like the back of your hand. And it has been found that even the most brilliant of people can only remember up to 30 to 40 drugs. And we don't have all the people who are brilliant. So for an average person, I would say you can only know 20 to 25 drugs like the back of your hand. And that is bare minimum. If you're prescribing a drug, you need to know about it, right? So it is better to know lesser drugs very well rather than to know all the hundreds of drugs, but very poorly, then you will not be able to use them properly. Next, please. So what is a prescription? Let's define a prescription. It's a written order from a physician to a pharmacist for dispensing the medicines for the use by the patient. It's a legal document. It should be legible. There should be no ambiguities. It should be properly dated. And the doctor has to take the responsibility for the prescription by signing it clearly. And those signatures, they should be readable signatures, not just jotting down something which is absolutely not readable. So it should be signed clearly. Next one. So these are the parts of a prescription: superscription, inscription, subscription, transcription, and signatures of the prescriber. Next one. So let's learn about the superscription. Superscription means there should be date, details of the clinician like name, degree, designation, registration number, and phone number, so that if need be, patient can contact. Then details of the patient like name, age, gender, and address. And then I'm sure all of you have seen the symbol RX, which is written at the beginning of the prescription after the personal details of the patient and the doctor. You write RX. take thou. That is the recipe. All right. Next, inscription. This is the main body of the prescription and the most important part of the prescription. What does this part contain? Name of the drugs. So name of the drug should be legible, it should be generic, and now the current day requirement is that it should be written in capital letters. And we must mention about the appropriate drug formulation, and we must mention the required strength. So these are all the important ingredients of the inscription. Next one, please. Subscription. Subscription usually is not written. These are the instructions for the pharmacist that what he is going to dispense. All right. And this was important when compounding and dispensing used to happen. So these days, everything is available in the market. So subscription is usually missing. From the transcription only, pharmacists will understand that how much medicine is to be given to the patient. Next one, please. So this is another very, very important one, which has already been emphasized, that your diagnosis may be correct, your prescription may be correct, and yet patient may not be benefited. So one of the factors is if your transcription is not good. So what is transcription? Transcription is directions for the patient for using the drug appropriately. So regarding, you must tell about the route, you must tell about the frequency, that how many times a day person should be using it. And in fact, it's always a better thing to mention the times on your prescription. Then what is going to be the duration of the treatment, at what time of the day, and other things like the correlation with food, it is to be taken with water or how much water. So all these things are part of the transcription. So important instructions, they must be given to the patient for the absolutely proper use of your prescription. Only then you can ensure the best therapeutic outcomes. Next one, please. Then signatures of the prescriber, authentic full signatures, full name below the signatures, and every practicing doctor is supposed to have a registration number. All right, so that registration number should be mentioned. Next. Then critical evaluation of a prescription. So what are the general points which you like to see? Legibility, abbreviations to be clear and appropriately placed, avoid unnecessary use of decimals, the ink use must not be washed off easily, all the parts of the prescriptions to be complete, and if you want to make it a good prescription, you must consult a checklist, and that's what I will give to you next. Checklist. Next one. So this is the checklist. So legible handwriting, capital letters, good quality ink, and see to it that all the parts of the prescription are complete. Next, please. Then look that all the inscription part is also complete, that drugs have been written in generic, all the drugs are rational, and any harmful drug interaction or irrational drug or banned drug, it must not be written at all, right? And then subscription, that is all the instructions written for the pharmacist regarding doses and route, strength, frequency, duration of treatment, etc. Next one. So then transcription. Transcription means that complete understanding to the patient. And let me tell you something here. What is important is not only the written instructions, you need to communicate the whole thing verbally also. And please ensure that your patient has understood it all. Even if you need to write in Hindi or any vernacular language, it does not matter. But the ultimate idea is that your instructions should be absolutely nicely understood by the patient to have the best possible therapeutic outcomes and the least harm. Okay. And is the signature of the clinician present at the end? And the abbreviations used are correct and properly written. So if you keep in mind this checklist, and again, I would like to say what I said earlier, that this checklist needs to be remembered in the brain, but it should also happen to you spinally. Then only your prescription will come out good. Next one, please. So this is the second part. Once we have written a perfect prescription, still we have done half the job. So what is next half of the job? That is communications for proper use of that prescription. Because combination problems, they lead to under, over, or incorrect use of the medications, and patients may suffer from unnecessary adverse effects because of these reasons. All right. So that is very, very important. So how do you do that? Let's discuss that. Next one, please. So this is the checklist for communication to the patient. So first, what is important is communication etiquettes. So what are the communication etiquettes? When you're discussing your prescription with the patient, speak softly and slowly. Speak in a simple way and in a language which the patient understands. Don't try to use unnecessary medical hi-fi terminology. And you must sum up the important instructions in the end. And before the patient leaves, encourage the patient to speak back to you what has been understood about the use of medication. And if still you feel that there is some lacuna or gap, you please clarify that again to the patient and make him speak again till the time you are sure yourself that patient has understood your instructions. And if at all there are any questions by the patient regarding the prescription, please answer them patiently. Next one, please. So what are the important things which you need to communicate to the patient regarding medication? Very clearly explain the dosing schedule. Very clearly explain the route of administration and site of application. The medication technique, how it is to be taken, like if it is to be taken sublingually, how that is to be done. If it is to be taken orally, then you must explain that at least 100 ml of water must be taken so that patient ensures that the tablet goes into the stomach and doesn't stick into the esophagus causing great harm. Then you must inform the patient regarding the expected ADRs and must tell when the drug can be withdrawn or cannot be withdrawn. So adherence and compliance needs to be explained again here. And must information regarding the storage of the medicines. Like few medications, they need refrigeration. Few medicines can be kept at the room temperature. The medications, they need to be kept away from the reach of the kids. So we have to find out the appropriate storage sites at our place. Fine. And what is the association with food? Is it to be taken empty stomach or is it to be taken after the food? All right. So all these things are very important communication points for the absolute safety of the medications. Next one, please. So this is a case scenario. Write a rational, correct, and legible prescription for the following patient and communicate the same. So this is talking about a boy, Mohit, an 11-year-old boy, came to OPD with difficulty in breathing, with expiratory wheeze and coughing. And examination is NAD, physical examination. The patient is having this problem for the first time. He has been suffering from a viral fever for the last 1 week. The patient is diagnosed to have acute attack of asthma. The drug to be prescribed is salbutamol, 1 puff using a multi-dose inhaler every 6 hours and follow up the visit next day. All right. So let us see the prescription, how this would sound. So this is how it should be. On one hand, there is the information that is date, that is superscription. Patient name is Mohit, age is 11 years. The phone number of the patient is given. And then Dr. Mohan, his designation, his registration number, his contact number. Then comes the mark of superscription. The drug is salbutamol, written in capital letters, multi-dose inhaler, 1 PEF QID, that means 4 times it in a day. So underneath, very clearly the instructions have been given. Use the inhaler 4 times in a day. Always carry the inhaler with you and revisit tomorrow. And then please, for God's sake, in such patients where somebody is using a device, we need to explain nicely to the patient the technique to use the inhaler. Half of the patients actually, they are given the inhalers and they never know how to use the inhaler. Most of the medications is going waste actually, right? So this is one example of a good prescription. Next one. So I think we can pass it off. This is another condition, but I have given you the principles. Do we have something more? Please go on to the next one. Next. All right. So that's all about it. So I have discussed with you what a prescription is, what are the skills which you need, what are the parts of a prescription, how do you ensure that your prescription is good. You must use the checklist. And finally, the second part of prescription is communicating beautifully with the patient so that patient has no lack of understanding on the prescription which has been given to him. If you do that, I'm sure you will be avoiding the medication errors. And before we close this talk, I would like to say few words about medication errors. Now, why medication errors happen? Medication errors can happen at all levels, The prescriber is the first and foremost person who can lead on to medication errors. Why? Because they are busy people. They are the overburdened people. The OPDs are full of patients. They don't have the time and the patience. Sometimes they may be talking on their mobile phones when they're writing prescriptions, and such kind of factors, they can have a huge bearing on the quality of the prescription which is given by the doctor. Then comes the responsibility of the pharmacist, who may not be actually giving the medicines which have been prescribed. He may give the poor alternatives. He may substitute the treatment. He may not be dispensing the right amount of the medication. Fine. So these are some of the important problems which can happen at the level of the pharmacist. And then the biggest problem lies with the patient himself. They may not be compliant to the treatment. Sometimes they are under compliant. Sometimes they are over compliant. All right. So this can be another area of problem, that they may not follow the instruction. Either they haven't understood it, or they are careless enough not to follow these things. So they can cause. So these are the people who are responsible for medication errors. Now, where can the medication errors happen? They can happen in superscription. They can happen in prescription writing. They can happen in dispensing. They can happen in transcription. They can happen in communication. So anything out of these is lacking at some point of time, invariably this will lead on to medication errors. And it is easy to say medication errors. They have huge amount of implications. They cause unnecessary problems. They increase the cost of treatment. They increase the number of hospitalization. And last but not the least, when patient suffers, there is a loss of trust between the patient and the doctor. And if this happens, then the battle is lost already. Fine. So we have to be very, very careful. We should avoid all kind of medication errors, and that only we can do if we write an appropriate prescription, best of it, and then we communicate it in the best possible manner. If we do that, largely we'll be doing a great service to our patient, and in the process, we'll be doing a great service to ourselves. Fine. So I'll be happy to respond to any queries which any one of you can be having. Thank you so much.
Thank you so much, sir, for such an informative session from your side. We are all really thankful for all the information that has been provided by you. We look forward to all the doubts that the participants have. Kindly send that in the chat. We'll be getting back regarding the same to you after the webinar. Also, we'd like to present a vote of thanks to all the three esteemed panelists for taking time out of their busy schedules and presenting their valuable information and golden words of wisdom for all of us. I would like to hand over the mic to Shrutika to continue the vote of thanks.
Thank you so much, Shikhar. I would like to thank Dr. Bhavesh, Dr. Manisha, and Dr. Mahesh for gracing us on such an occasion of World Antimicrobial Awareness Week and providing us with such extensive knowledge on AMR resistance and prevention. Thank you so much for, as Shikhar mentioned, coming to us on this platform on such a short notice. We really value your time and contribution to our webinar. Thank you so much, Shikhar. Back to you. With this, I would also like to inform all the participants that a post-event webinar form has been shared on the chat. Kindly fill the chat form. The form will be open for 20 minutes, and the form is necessary to be eligible for certificates. We also ask all the participants to first of all switch on their camera so we can have a short quick photograph before we free sir of this panel. Thank you so much again. We request if everyone can show up either in blue or hold any blue object that might be lying, since the AMR Awareness Week has the Go Blue motto. We would like if anyone can have some blue in their screen. Neil, are you clicking the picture or should I?
Yeah, Shrutika, you can go ahead and click the picture.
All right, so there are multiple screens, so I'll be clicking the picture in two parts. All right, if everyone's ready, kindly stay still for 30 seconds, I will say. Ready? 1, 2, 3, click. Another. Click another. And one more. Done. Thank you so much, everyone, for joining in. Please make sure you fill the form before leaving the meeting. The form will be open for 20 minutes. If you have any questions, you may also add it to the form and we'll pass it on to our experts. We are respecting the time and everyone's commitments with regards to any other work that they might have. So we are not extending this panel anymore.
I need to say something before we finally.
Yes, sir. Yes, sir.
Yes, sir.
Definitely. The floor is
think,
all yours.
all of you young people, you are the hope for tomorrow. Fine. So I think I would like to convey to all of you my best wishes for your personal and professional success. And